and the Program for Education in Humanism, Ethics, and Professionalism. And I want to welcome you to our Dean's Foundation Visiting Scholar in Humanism program. Alison Wichman is going to be speaking today, and she's going to be talking on approving medical research on humans and good judgment be often evaluated. So Dr. Wichman is here at the NIH. So this is the old NIH. You're going to see the new NIH in just a moment. The new improved, but I don't necessarily agree with that judgment in terms of the architecture. But anyway, she's as a past director of the Bioethics program at NIH, and she also helped create the NIH Office of Human Subjects Research, for which she is the acting director. So she obviously has a deep and dear interest on human research subject protection. So I give you Dr. Wichman.
Thank you. How do I advance this, David? This way?
Yes.
Just click.
Actually, you can also hit the forward arrow key on the keyboard.
Okay, great. Well, it's a real pleasure. I appreciate the invitation, and I am very happy to be here. I am a native Lexingtonian, and so it's always a pleasure to come back to my home state. I love Kentucky, and in addition to being very tied to Kentucky, I was very interested in the Ethics Center. Dr. Rothstein unfortunately can't be here today, but we had breakfast together, and he is doing many interesting things in ethics, and I always like to hear and see what my fellow Kentuckians are doing. I was looking over the previous lectures, and I was a little bit nervous when I saw that, because I basically have given up giving lectures. I don't give many lectures anymore. Because of what I do, human subjects protections, I find that case seminars and small groups and mock IRBs, actually having IRBs in small groups, is much more in keeping with what I'm interested in and communicates, I think, mostly what I'm trying to teach. But I am happy to give this lecture, not so much in that I'm going to be telling you what I think, but also in asking your help. And in light of that, I want to know how many of you are currently or have served on IRBs. So a few. And then on ethics committees, I think there are a few ethics committees members here, and some do both. So in a sense, that's great, because what I'm going to be talking about is decision-making processes, and so whether that has to do with IRBs or ethics committees, I think there's a large crossover in that regard. So in terms of having given up the lecture series and the lecture circuit, because it takes so much time and you can spend your whole life traveling, it reminds me of Billy Collins, who was the previous poet laureate, who said when he was the poet laureate of the United States, he spent his whole life traveling, and all he did was come home and drop his suitcases, and he had no time to do anything else, and he had changed his motto from carpe diem to carpe podium. So you can be assured that I have not carpe many podiums lately, but I welcome this topic, which really is, what do we expect of IRBs, and how can we look at their performance? As many of you know, the whole issue of what IRBs do and how they do it or how they don't do it, the IRB system is under strong criticism right now, is very much in the fore. And while I've been thinking about this for some time, when I was in college, in fact, my senior philosophy paper was on ethical decision-making procedures in human subjects protections, and little did I know that was 1974, that, you know, years later I would be doing the same thing. In the meantime, I forgot all of that because I went to medical school and did a residency and practiced neurology for quite a while, so little did I know that what I was interested in college would come back into use and be helpful to me now. So as David said, this is the clinical center of the NIH, the way it looked when it opened in 1953. And I thought before I jumped into the topic today, I would just remind you tell you a little bit about what I do. And as you know, the NIH is the government's largest and federal agency dealing with the advance of scientific knowledge about human disease. and it is a taxpayer-supported entity to the tune of $26+ billion now, which is a lot of money, and most of that, in fact, goes to the extramural program in the form of grants. So the University of Louisville is one of the major receivers of NIH funds to do research. A small amount, about 10% of that budget, stays in the intramural research program that is physically located on the Bethesda, Maryland campus, and this is what the clinical center of the NIH looked like in the 50s when it first opened. This was designed as a research hospital. It had, when I went in 1982, about 500 beds, most of which were full, and all dedicated to the conduct of research involving people, which is quite different. Most institutions, such as the University of Louisville, of course, are a functioning hospital that do routine clinical care and also do research. But in our hospital, all we do is research. And so, as a part of that, the tradition of looking at human subjects protections developed quite early. And in fact, the thinking is that NIH, the clinical center, probably had the first IRB. It actually, when it opened in 1953, had a committee of individuals to look at research only involving healthy volunteers, by the way. Research involving patients and ill persons was left up to the discretion of physicians in consultation with their physician colleagues, but research involving healthy volunteers was reviewed by this committee, and in fact, the first two protocols that were sent for review to the committee were disapproved because they were felt to be too risky. So I think that was pretty interesting that colleagues would be willing to say that research was too risky. So now this is what it looks like today. As you can see in the background at the top, with the building with the two wings, is the structure I just showed you. The middle structure is the ambulatory care facility, and then this whole new area is the new research hospital, the Mark Hatfield Clinical Research Center, and it has about 250 research beds. It just opened in 2004. It was delayed for some time because bathrooms didn't work and heating systems were not up to snuff, but we finally opened in the fall of 2004. For those of you who are art history fans, this is a Louise Nevelson sculpture in the front. Now, at our institution, we have quite a large human research protection program. As many of you know, the University of Louisville has recently obtained accreditation by AHARP, the Association for Accreditation of Human Research Protection Programs. And over the last 5 or 6 years or so, the notion of a human research protection program has come to the fore. That is, a program that involves institutional officials, the roles and responsibilities of institutional officials, IRBs, and also roles and responsibilities for researchers and research staff. So there's sort of a contextual idea of what human research protection is. There was, in the old days, 5 or 6 years ago, it was pretty much IRBs on their own, in a sense, within an institution, some with more or less support within the institution, but because of the series of disasters within the field of human research protection program, it was well clarified that an IRB functioning in isolation in an institution doesn't work, and that in order to really protect human subjects, there needs to be a cultural context in which IRBs function. And so the notion of a human research protection program has appropriately come to the fore. And in our human research protection program, we have 14 IRBs. Not because we have so many protocols. In fact, I was just talking with Dr. Martinez earlier today. I think the University of Louisville has about 18 or so hundred protocols. I think he said that was about right. We have about 1,300 protocols, but almost all the research that we do, or much of the research that we do, I consider in the dangerous range. That is, you can hurt people. You're giving them medicines, or you're using biologics or devices, or you're doing gene therapy, or you're doing neurosurgical research. So while we may not have so many numbers of protocols, the kind of research we do is often pushing the edge of the envelope and requires careful attention. So as many of you, all of you know, the U.S. system of human subjects protections is based on established ethical principles articulated in the Belmont Report, which I'm sure many, or if not all, have read, federal regulatory requirements, and then local institutional and other requirements and procedures. And for those of you who have not served on an IRB but have been on institutional or healthcare ethics committees, in a sense we could say IRBs have it easy because we pretty much know the framework in which we're supposed to work. When ethics committees were first coming into being, they were pretty much on their own trying to figure out how do you analyze an ethical problem in medicine, what is the framework we should use. So I think those of you who have served on ethics committees may say, well, boy, it would really be nice to have had all these guidelines and requirements when we started thinking about clinical ethics consultations. But it is deceptive because while it seems like there's clarity, it often can be much more complicated than one, deceptively more complicated than one thinks. And I'm not going to deal to a large degree with why our system has come about. I think most of you are aware of that. But the main cornerstones of all federal regulatory requirements for protecting human subjects is based on, to a large degree, prospective review of research by convened groups called IRBs, or Research Ethics Committees, addressing particular human subjects protections issues, and subjects informed consent. Now, of course, I'm not going to talk about informed consent today except in passing, but these two cornerstones basically are the framework for the U.S. system for protecting human subjects. And really, it hasn't changed in the many years. Well, in 1981, the regulations first came about, or 1983, and to a large degree, the system has not changed in its basic formulations. The reason this system came about is, as many of you are well aware, is many ethical dilemmas and disasters occurred that forced us as a nation and as a research community to decide that if researchers were going to have the privilege of conducting research involving people, there need to be clear guidelines, and we needed a system for deciding whether or not the research being conducted was ethically permissible, in keeping with some agreed upon ethical principles and requirements, and also how we could hold institutions accountable for the decisions they made about what research would and would not take place. Now, the other point is that in terms of the system not changing to a large degree, the research activity itself has dramatically changed. That is, when I went to the NIH in 1982, about 70% of research was funded by the federal government. Most of the research was funded by the federal government, and most of it was conducted in academic medical centers. Now, of course, in a short years, just the short 20-plus years, that demographic has switched to where almost two-thirds of research is sponsored by private and pharmaceutical sponsors, and about a third is conducted and supported by the federal government. And that's a huge change. The biggest change probably is what we all know, and those of you who are in academic centers and in centers where private practitioners are doing research as well, is that research is now big money. And that is a big, big change in just a few short years. The other point that I want to make is, as you know, while this is the basic framework, not all research conducted in the United States is covered by the federal regulatory requirements. Again, I think most of the dangerous research is. Most of the research supported by the NIH, or all research supported by the NIH, and under the regulatory purview of the FDA, is covered under these federal regulatory requirements, but not all is. For example, if a private foundation supports research, it is not a requirement, a federal regulatory requirement, that be held up to the same standards. although most of it is. And again, I think most dangerous research is covered by regulations because, of course, research involving drugs is generally sponsored by pharmaceutical companies, and while it may not be under the regulatory purview of the NIH, it certainly is of the Food and Drug Administration, if in fact the point of the research is to get a marketable drug. So all research leading up to the intention of marketing drugs is covered by the FDA's regulations. So this is what I'm basically going to deal with today, and I do hope that if you have any questions or comments that you can feel free either to break in during the discussion or certainly after I give some introductory comments. I'm hoping to get some discussion going. I'm particularly interested on the basis and by what process IRBs ought to make their informed decisions about the protection of human subjects in research. And certainly you can see that this is a question that's appropriate to ask of institutional ethics committees too. How do they make decisions? On what basis ought they make decisions? And if we can clarify that, then perhaps we can come to some agreement about whether we can evaluate their performance in making these decisions, and actually that's my interest. My interest is currently, and what I'm getting ready to start at the NIH, can we develop an instrument and an evaluation procedure for evaluating what happens in a convened IRB meeting and the rightness and wrongness of IRB decisions. And I'll talk a little bit about right and wrong in the context of IRBs in a minute. But, I mean, this is a really important question because there are thousands of IRBs around the country. We're not sure how many. I guess OHARP, now that it's registering IRBs, probably has a number. I don't know. Does anybody know what that number is? Before OHARP, the Office for Human Research Protections, which is an office in the Department of Health and Human Services, before they started registering IRBs, they thought between 5,000 and 8,000. And so my guess is there would be thousands to over tens of thousands within this country and many outside. And so this is not a silly question or a question that doesn't deserve serious evaluation, because when you have thousands of groups doing the same thing, one should at least expect some consistency across the process, if not the outcome anyway. And if we can agree on what IRBs ought to do, then we can begin to evaluate whether or not they're doing it or not. So just a quick run-through of what the federal regulations do say about who should be making decisions about what research occurs and the protection of human subjects, and also what criteria these groups should use. Now remember that the regulations, the 45 CFR 46, are regulations that I love to love, because while everyone else complains that they're too broad and too vague, that is what I like about them. I like the fact that while they are quite specific in some ways, they are also broad enough that if you get the right kind of people sitting at a table and they know what they're supposed to be doing, that leaves quite a bit of leniency of that decision-making process that's appropriate in many cases. So many people do not like the current regulations, but I actually think that they have many strengths. And I'm not an advocate of getting as much guidance from OHARP as possible, because the more guidance you get, the more restrictive it is. So just a brief run through. All of you know this, that the federal regulations do say that there should be a minimum of 5 individuals on an IRB, that the IRB shall be sufficiently qualified through experience and expertise, and the diversity of its members, including consideration of race, gender, and cultural backgrounds, and sensitivity to such issues as cultural attitude, to promote respect and counsel in safeguarding the rights and welfare of human subjects. Well, this does say a lot, actually, and before I go into the second bullet, let me just remind you that in terms of the minimum number, the regulations do say that you need 1 member whose primary interests are scientific, 1 member whose primary interests are non-scientific, and one member who is not otherwise affiliated with the institution. And that somehow has become translated into a lay or a community representative. And I understand how that's happened, that we have a lot of concern that IRBs do reflect the values and attitudes to people who are in the subject selection. For example, if you're going to study Native Americans, you should have people who can reflect those cultural values and the concerns of that group. But I think we should remember that the regulations don't talk about lay individuals or community representatives. They do talk about non-scientists and unaffiliated members. And I was always interested. I had a student who did a study with me one summer about our unaffiliated members on our IRBs. We have, out of the 14 IRBs, I think 28 individuals. And I was very interested in how that came about. What was the reason for having an unaffiliated member? And some of you may know Charlie McCarthy, who used to be the director of OPRR and was a Paulist priest who got a PhD in political sciences. I asked him that question, and I was really just amazed at the answer. The reason that the regulations included a non-affiliated member was the framers of the regulations felt that those individuals were more likely to be whistleblowers than people associated with the institution, which is very interesting. The idea of a whistleblower did not immediately come to mind in my thinkings about membership, but because of the environment in which the regulations were framed, the idea of a whistleblower was very important, because most of the ethical dilemmas and disasters that occurred within research probably would have benefited from a whistleblower. Certainly Tuskegee would have benefited. In fact, that's how Tuskegee was uncovered. Someone wrote an article in the press, and the people involved with the syphilis study began to complain about the ethical aspects of that trial. So the bottom line, really, of at least the membership of IRBs is that human research subjects are most likely to be protected by a committee process in which the membership is diverse in professional, cultural, experiential background, knowledgeable about human subject protections issues of a particular protocol. That is not just the theoretical regulatory issues, but what issues are presented by what is in front of us at this moment, a particular research protocol, and in individuals that are sensitive to the location, that should be here actually, of the research. Now, this is a leap of thinking, because the regulations don't necessarily say that close to the location of the research is the issue, but I think the notion that IRBs that know and understand the context in which the research is to be conducted, including the place and the investigator, is a valuable asset. And this is one reason why the whole issue of regionalizing or centralizing IRBs has been a hard go, because I think most people who do work with IRBs and work on IRBs, while the local nature of them means that it's harder sometimes for us to educate ourselves and to be consistent with other IRBs across the country, this local nature, the closeness of the ethical activity to the research enterprise, offers very strong advantages. And it is interesting that even where there are central IRBs, for example, the National Cancer Institute does have a central IRB that will review protocols that then will be conducted at many places, ECOG and other places. IRBs are and institutions are very reluctant to give up the local review, not because they don't trust the central IRB, but because the central IRB does not offer that particular expertise of being close to and knowing the environment in which the research is to be conducted. So while IRBs are under current criticism from many fronts, this whole issue of local review continues to be a challenge, and it's one reason why I'm talking about what I'm talking about today, or what I'm going to talk about. I'm not going to deal with this in detail, but only to tell you that there is a clear framework for IRB deliberations, and this slide does not make sense, but basically what an IRB at a minimum must do in its deliberations, in its convened meetings, in the process of reviewing research, is to address for any particular protocol the issues up here. These are straight out of the regulations. There's nothing magic about the words, but they're kind of complicated, and towards the end of the talk, before we begin our discussion, I'll deal with these in a little bit more detail. But certainly scientific design, at least a research study that has the possibility of accruing knowledge. It is designed in a way where data will be generated and where the design of the study leads to some analyzable information, that the risks of the research are identified and risks wherever possible are minimized, an evaluation of the prospects of the benefit to subjects or others. We do a lot of research that offers no direct prospect to the research subjects, for example, healthy volunteers. That research is all done with the cooperation and participation of healthy volunteers, but for the purpose of developing generalizable knowledge. An attention to the selection of the subjects in the protocol under review, a review of informed consent documents and process, when appropriate, what steps are being taken for privacy and confidentiality, data safety and monitoring, and then any special protections for vulnerable subjects. Now, you know, you've heard this a million times, you know, this is easy, this is what you're supposed to do, but in reality, I think it's very hard for an IRB to do this in a methodical, systematic fashion. And as I develop this idea, I think if every IRB around the country did this regularly, systematically, and methodically, and documented the decision, we would be in much less trouble as an activity as IRBs are now. So I just want to say, before we start talking about how we're going to evaluate IRBs, is what really do we expect them to do? Well, we expect them to protect human subjects, certainly. But remember that IRB decisions are process-oriented. That is, a successful outcome is determined by the correct process. And we can talk about that a little bit as we move forward. IRBs ought to be made up of diverse, knowledgeable people that are sensitive to the local conditions, and they render informed human judgments about clinical research. The informed nature of the judgment is that they take into account the ethical principles and regulatory and other requirements, that the judgments are based on an understanding of the specifics of the protocol, the material facts of the case, in a sense, in lawyer talk, that is, the details of the conduct of the research that's important to the protection of human subjects, that they engage in a systematic deliberation in a convened meeting, that they make a decision, they render a decision and document it, and then they're held publicly accountable for the decision-making process and the outcome. And each of these steps is important. If you leave out any, you're in trouble in the sense of being able to justify the decision. And I think that IRBs around the country and research protection programs are being shut down or being criticized, not because they're doing this, but because they may be doing this to better or worse, to more or less degree. But there's one area that's missing. Either they don't deliberate on the protocol in the context in which it's going to be conducted, and that's one idea of why you need more community representative, is that you have people on your committee who really bring to the fore the material facts of the case, or they're not doing much in their convened meetings. Everything is done ahead of time by the IRB office staff, and it's put on the table and said, okay, are we ready to approve this research? Well, everything may be in order in that protocol, but that's not what the regulations say. The regulations don't say you approve research that's been pre-digested. The regulations say that in a convened meeting, you go through a meaningful process. And if everything with that protocol looks perfect, then at a minimum you can say, we believe that the selection of subjects is appropriate, or we think the investigator in the IRB office has presented it but hasn't gone far enough, for example. So the regulations do put a high stock on the convened aspect of that meeting, and those of you who have been on IRBs understand the convened context. Things can go well or they can go not so well. You can get lost in an issue that doesn't have much meaning to the protection of human subjects. You can have an hour-long discussion about why it's appropriate or not to involve these people with dementia in research. It sometimes can be a volatile environment, just as ethics committees can be a volatile environment, but that's the part of it that adds to its uniqueness, in a sense, in rendering a human judgment. Human judgments and the formation of them can be messy, right? And we should be able to live with that ambivalence and ambiguity while realizing that that's a very important part of the process. So, you know, I was talking with Dr. Martinez earlier today, and I think that there's very little discussion of this and what IRBs do and how we can evaluate them. And maybe it's because everyone else in the world knows and understands this, and I'm in the minority. But I have been to hundreds of IRB meetings over the years, mostly within the NIH, but other places too. And it is unusual for me to hear an IRB march through these issues in a methodical and informed way, in a way that I think I can say, well, more or less, that I can say this IRB has met the letter and the spirit of the regulations. I wouldn't say it's rare, but it's not the norm. And I'm saying that our IRBs, I think, do an excellent job. I mean, we have 14 of them, and they, you know, I don't know how many IRBs protocols on your agendas, but maybe 10 new protocols. Our IRBs have much more luxury of time, so they can afford to spend an hour on a protocol. But I don't think that's I think that my interest over the years and now, and what I'm going to be talking about now, is how do we evaluate the performance of an IRB? So I actually believe that if we drew from some of the knowledge and skills of our philosophical and legal scholars, that we would have an easier time of it. And I'm very taken with John Rawls. I had studied him in college. When I wrote my senior thesis, I read a lot about John Rawls, and I think he really does frame the issue and gives those of us who are in decision-making processes and learning about them sort of support for trying to come up with consistent and methodical ways of thinking about problems. And this is a wonderful paper. If anyone's interested, I have an extra copy. I'd be glad to give it up. And anyone interested in decision-making processes should be encouraged that John Rawls and many other of us do believe that there is a decision-making procedure which is sufficiently strong to determine how to deal with competing interests, how they should be adjudicated, and when conflict arises, to make a decision. And certainly this paper has nothing to do with IRBs, but it does have to do with decision-making procedures in ethics. And he was not interested in bioethics in particular, but he was very interested in, if you can decide what reasonable principles, when we are given a proposed line of conduct and the situation in which it is to be carried out and the relevant issues which it reflects, will this enable us to determine whether or not we ought to carry it out and hold it to be right and just. And this is just really a variation of the few slides that I showed you previously, talking about rendering human judgments. And when do we know that a human judgment that an IRB has made is informed and can be held up to outside scrutiny? And this is a wonderful paper. I'm not going to go into it in any more detail now, but I do think that it's particularly good because he deals with not only the kinds of decisions that need to be made, the principles by which those decisions are made, but he talks about the kind of people who are best positioned to make those decisions. And if anyone is interested in the conversation going on now about choosing a Supreme Court justice, this is the paper for you, because he does talk about competent moral judges and the kind of qualities that brings people to the table and allows them to think systematically about problems, and the kind of people, by the way, we would want to make decisions on our behalf, which is certainly the case for ethics committees, IRBs, Supreme Court, all the groups that render human judgments on our behalf, the kind of qualities we expect in those people. And I think where this is relevant to IRBs is that while we label members, we want a scientist, we want a non-scientist, we want an unaffiliated member, we want a bioethicist, we want a lawyer, maybe we're paying more attention to the label and less to the qualities that that person brings to the table. And I think in terms of the IRB's activities, it doesn't matter whether, well, you do want people who are non-physicians and not invested in the research. But, for example, there's nothing about a physician particularly that makes him or her more skilled in making ethical decisions. There's nothing, that's what Bob Beach would call the expansion of expertise. Just because you're a doctor doesn't mean that you're more able to make an ethically clear decision, unless you've been trained to do that, or you've taken Dr. Ducas's course and know what, and any medical students in the room know that along with going into medical school, now you're being trained to think about the ethical dimensions. I assume you three don't have any gray hair, so I assume you maybe are the philosophers or the medical students. But there's nothing, and Ed Pellegrino, I think, must have mentioned this in his talk about how much ethics do we expect doctors to know. There's nothing about being a physician that automatically means you're better at thinking about ethical issues. So I think that one of the things left to be done in IRB decision making is to look at those qualities of people who are engaged in the decisions. So that leads us to the things that I'm hoping that we can have some discussion about. If what I assume is the case, what I've been saying before, then the question is, if there is a reasonable decision-making procedure for IRB, human subject protections reviews, can we teach it and can it be learned? And also, can the deliberative process of convened IRBs be evaluated to determine if they're fulfilling the letter and the spirit of the regulatory requirements? Do we just throw up our hands and assume that if IRBs are made up of the right people and they're deliberating about the facts of a protocol, that we have no sense of when an IRB makes a more or less informed decision? I actually think that if I asked anyone who is familiar and knowledgeable in human subjects protections to come to one of our 14 IRBs at the NIH and sit in on that meeting and then come to me and tell me whether they felt our IRB was meeting the letter and the spirit of the regulatory requirements, I would think you could do that. Because you're experienced, you've done it before, you have a knowledge of all of the things that the IRB, now you might not know the details of the protocol, but I do think there is place for evaluating what happens in an IRB and whether or not we are fulfilling both the letter and the spirit. Now, this issue, the letter, in some ways is easier to deal with. The letter often involves paperwork, paper trail, minutes. I think there are many places where the letter of the requirements exist, but the spirit does not. And that's the spirit of protecting human subjects is almost an institutional and individual cultural idea. And I think where you have leaders of a program who see human subject protection as an important value, who support their IRB, give them resources for education, come to the IRB occasionally and say what you do is important. All the ways that an institution communicates to its IRBs and researchers is steps up the idea of the spirit of the regulatory requirements. Now, in terms of accrediting a program, one of the new activities in looking at human research protection programs, whether accrediting and doing the activity they're doing, short of attending IRB meetings, and the accreditors do not attend IRB meetings, I think they're missing a huge opportunity to learn. If they're accrediting institutions and they're going and talking to institutional officials, they're talking to PIs, they're meeting with IRBs, they're losing a huge opportunity to learn about the deliberative process of IRBs. And so that's why I'm interested in this issue, because no one else is doing it. And I decided that somebody had to do it, and I have no idea if I'm doing it correctly, but I know I'm doing it, and I'm trying to do it in a reasonable manner. So this is a really busy slide, and I'm going to stop talking here very soon, but I wanted to, these are the basic requirements for IRB review that I just in brief presented earlier, and I want to I'm not going to dwell on these, but I wanted to communicate that while there is a seemingly easy what IRBs are supposed to do, actually the knowledge and skills and facility with these review requirements are actually quite complicated. And so, for an example, the whole notion of what is a vulnerable subject. I mean, it's very easy when you're reviewing a protocol involving children to recognize that under the regulations, children are considered a vulnerable population. Because what? There's a whole subpart D, that deals with additional protections for those children, as well as prisoners and pregnant women and fetuses. So because the regulations specifically say, and oh yeah, if you're using these groups, there are additional protections, IRBs are left with quite a bit more leniency when, for example, looking at research conducted in an emergency room, for example, or using research subjects involving people with dementias or with mental illnesses. So there's a large degree then of informed judgment about what those additional protections are and how to implement them. And remember, it's not just implementing them in the review of the protocol, but then actually implementing them at the bedside. So I wanted to just put the regulatory language on the left, and then these are the kinds of things that IRBs grapple with. So, for example, we talk very simplistically, you hear this all the time, well, we did a risk-benefit analysis on this research. Well, you know, that's not quite it. What the regulations say is the risks to subjects are reasonable in relation to anticipated benefits, if any, to subjects, and to the information, to the knowledge to be gleaned. So the simplistic notion, and many people have actually worked on mathematical analyses, try to come up with sort of, you add, you know, a risk. For example, blood drawing might be given a number 1. That's a risk level of 1, whereas a cardiac cath might be a 3, and you add all this up, and you come up with a number, and then you have a way of identifying a risk-benefit analysis. And I think that really gets away from the notion of reasonableness. Now, that's not that easy to know what that means, but the assumption is that when you have a protocol that requires that, as all protocols do, but some more than others, that grappling with what it means for risks to be reasonable in relation to benefits, the IRB is sufficiently knowledgeable and skilled to do that. So you all know all the rest of this, I'm sure. Now I just want to talk a minute about risk. Again, let me just go back once, because the reason I'm producing or showing this is, if you notice up at the top it says IRB Protocol Review Standards. At the NIH, every time an IRB reviews a protocol, at least in its initial review, it is required to discuss and document in its minutes each of these elements for the particular protocol under review. Now, one would think that this is standard across the country. In fact, it's not, and even though we expect it, because we have so many IRBs, it's done to more or less degree. As someone has said, that any institution with 14 IRBs it just doesn't get it, and it's like herding cats. It is true, even if you have procedures across IRBs, to have them consistently engage in the same process is a challenge. So ideally, if you look at the minutes of any of our IRB meetings, each of these issues is discussed and documented so that whoever is looking at the minutes should be able to understand the basis on which the decision is made. And that's very important in an institution like the NIH, because we are in the sunshine. That is, we have to assume that everything we do, because we're supported by the taxpayer, will be reviewed by people who don't particularly think we're doing the right thing. So we want to make sure that the deliberative process of IRBs are very clear. The other thing we require in every protocol that is reviewed is a identification of the degree of risk, and this is in the regulations. This is nothing magic, but we have routinized it and made it a part of our system, so that we have a risk assessment of each protocol and then a determination by the IRB as to whether there is a prospect of direct benefit. And this language, again, the regulations are so good because the language prospect of direct benefit allows for quite a bit of informed judgment by IRBs. This often gets minimalized to expected or hoped for or therapeutic benefit. None of that really gets at what is meant by the regulations, which is the research intervention itself, is there a prospect that that research participation will directly benefit the research subject or not. So that language is very important, and an IRB that doesn't understand or appreciate that language is probably not going to be able to grapple with the most difficult ethical issues that come before it. And let's face it, where the research isn't very risky, probably doesn't matter that much. Well, it does. It matters because it's important, but where it really is important is in research that's innovative, that pushes the edge of the envelope, that has the potential of hurting people. And that's where, if the habits of mind, if the IRB doesn't have the habits of mind of thinking through things, it's going to leave something out. It's not going to have this deliberative process that is ingrained, similar to like your doctor when he comes in and does your exam. If you're complaining of respiratory distress, he's not going to not listen to your lungs. He's going to do that, or she's going to do that. So while certainly an IRB decision-making process is not the same as the physician's decision-making process, if I as a neurologist examine a patient and forget to check the reflexes, I'm just as deficient. I'm deficient in a standard of care, and an IRB that doesn't talk about vulnerability or minimizing risk is equally deficient. Different areas of decision making, but similar kinds of strengths and weaknesses. So I'm just going to tell you now briefly, very briefly, and then open up because I know people are leaving, is what I'm doing. So what I did was a few years ago, I have a very small department, but I am lucky to have smart students who come in the summer, and I had a student who was in an MD-JD program. And many students are very interested in international collaborative research and kind of what I call sexy topics. But we started to talk, and this student was very interested in helping me evaluate and developing an instrument for evaluating IRBs. So he and I and one of my other colleagues in our office developed a draft instrument that we felt, if you went into an IRB and listened to the conversation, could formulate some idea of whether that IRB was protecting human subjects. And that got lots of criticism from our IRBs and people who didn't think that was a good idea because every IRB is different, and why would you want to do something like that? Now we're getting ready to move into the second phase, and so actually next week we have our first training program for people who we've invited. I think there are 8 evaluators, 6 within the NIH and 2 outsiders, who we're going to discuss the instrument with and have them attend IRB meetings and there'll be 3 going to each meeting and evaluate the IRB's review of that particular protocol. Then they'll come back, they'll use the instrument to rate that evaluation. They'll rate the instrument, tell us whether they think the instrument itself has been effective in helping to their judgment as to whether the IRB did its job, and then we'll have a debriefing and discuss the different opinions around the table. And what we're hoping is, after I think 10 meetings, we're working with a statistician who's been very helpful to us, would be to come up with an instrument that we think is better than the one we have now. And I certainly wouldn't advocate that this instrument be used anywhere else but the NIH, but anyone interested in using it is welcome too. I mean, there's nothing about this instrument that wouldn't be useful in another institution, but we're really not looking beyond the NIH now. We have a big enough problem on our plate with 14 IRBs. But anyway, I'd be very interested in, I'm going to stop now, I went over, I know, but I'd be very interested in some of your thoughts about this aspect of what we expect ethics decision-making groups to do and how to evaluate that. I mean, so I think I'll stop there, and I think...
My experience with IRBs in their selection process of getting people such as John Rawls recommends, and which we all recognize are needed, is considerably hampered because we have some people of rigid thinking who are actively seeking the point.
Well, remember what Rawls says, you've read this article, is the question was that in terms of picking IRB members, that there is a problem because there are people with fixed attitudes and ideologies seeking IRB membership. And what I was going to say before finishing that is what John Rawls says, one of the things is that a rigid ideology is exactly the kind of person you don't want to be a competent moral judge, because the outcome is almost predetermined if you can't put your own opinions into a neutral stance for this. So
it seems to me that problem is mirrored in what's going on with the FDA, which is something of the national IRB, and the difficulties that we had, for instance, just for an instance, with Plan B, that had been through all the routine examinations, was found to be scientifically acceptable, risks are acceptable, and yet it foundered because a member of a study happened to disagree on, shall we say, ideological/religious grounds, and won out. So that there are varieties of pressures at work in this whole process of decision making, not all of which are subject to rational analysis. And what are we to do about this?
Well, I think that is a complicated issue. I think the regulations are, at least for the protection of human subjects, which of course the decision about Plan B was made at an FDA higher level. Regulations specifically say IRB members ought not deal with the public policy aspects of a protocol, of the research activity. It's specifically, and I'll give you an example of that. The NIH in 1993, when President Clinton came into office, the first thing he did was to raise the ban that had existed on the use of fetal tissue transplantation. Reagan put that into place, and President Bush I maintained that. And the first protocol that came in, even before then actually, even before the ban was actually put in place by Reagan, stimulated by a protocol that was done at the NIH. It was reviewed by the IRB at the NIH. I was a voting member at the time, the NINDS, IRB, Neurology Institute. And specifically, the IRB realized that that aspect, the tissue, of course, for transplantation, was to be obtained from elective abortions. The IRB specifically recognized that it ought not be concerned or deal with that, although, of course, it did deal with the informed consent procedures of obtaining that tissue and knowing that a woman, knowing that that tissue would be transplanted, was different than its use in a petri dish, for example. And so I'm not sure what to say other than as a country, I think through our representatives or whatever way we make these decisions, is we have to decide what political influence we want over such decisions. I think that's something that as a society we haven't come to grips with, just like in our society, what relationship we want our government and our religions to be involved. So the problem, and we're seeing a similar thing in stem cell research, the problem with the government opting out is that there's a lot of good thinking that the government brings to bear on these issues, and I think that once, for example, by opting out of much stem cell research, the NIH and the federal government then isn't a player at the table. This was clearly true with fertility, with in vitro fertilization, where there was a ban saying, well, the government just simply won't fund that. Well, you know, that field developed within an ethical vacuum. Now, there were a lot of people who were making up for some of the problems with that, but I think the government opting out is a serious problem. But, you know, that's a difficult issue. Yes, sir.
My problem with the IRB is I've been on a long time. You aren't on it. And
Me?
yes.
Oh, I've been on
or
many
your colleagues. We get
Well, I've been a voting member.
Some of the most sophisticated problems we get
Right.
are neurology, are strokes, spinal cord
Right.
injuries, and with all the goodwill in the world, we have surgeons, we have pediatricians, we have anesthesiologists, we have radiologists. I think if you're going to do that first thing, is the study design appropriate, needs a neurologist.
Right.
And in evaluating the risk benefits, it needs a neurologist.
Right.
Somebody who has dealt with these patients over the years.
Right.
You just can't get an IRB that's got every
Right.
expertise on it.
Right. Well, that's, I think every institution needs to have a system of pre-IRB scientific review that is substantive. It is not fair to expect the IRB to provide that service. Now, they need to address those issues, but what my experience was, in fact, I attend many IRB meetings. I was a voting member for many years on the neurology IRB, and I understand what you're saying, but what I think one of the fundamental misunderstandings about IRBs is they were never intended to be scientific review committees. If you send to them a protocol that is not well designed, they simply should vote it down. They shouldn't be mucking around trying to patch it up. But that's one of the issues, is that generally IRBs are made up of colleagues, of scientists, and it's very hard for an IRB when something is not ready to come to it.
Take it the next step.
Well, send it back.
The scientific review is done by the chair.
Well,
The chair of the department in this
as a chair.
institution gets lab space by how much money you generate.
Right.
Now, you tell me that is going to get turned down on scientific endeavor.
I thought you meant the chair of the IRB. Yeah.
Are really great.
Right. Now, I don't know how the University of Louisville does it, but at the NIH, and this is just within the last 5 years, no protocol is accepted for review by an NIH IRB that has not previously been approved by a scientific review committee. Now, of course, because the NIH is what it is, there's quite a bit of flexibility in how that is done. For example, the Cancer Institute has a convened committee made up of all the senior branch chiefs that reviews each protocol, comes up with stipulations, requirements for changes, reviews the protocol. Again, it's not sent to the IRB until it is determined to be scientifically sound. Now, I'm not sure I agree with you that that should be a single person. I think that by putting that on a single person, right, it should be more than one person. So I don't really know what system would work. I don't know what you do here, but I think leaving it up to a department chair opens up all of the problems to, you know, the researchers who generate the most NIH money are more likely perhaps to get their protocols sent forward or whatever. But it needs to be a fair and consistent pre-IRB scientific review. And the standards for that should be clear. You shouldn't just throw it up. I mean, you know, if it should be clear on what basis the scientific review is being made. Would that help you?
Yes.
Right.
Very, very good thing.
Now, but I don't think that scientific review should, for example, be dealing with the informed consent procedures in the emergency room. That's an IRB decision. Yeah, and you know, the NIH has come up with some good systems. If you're interested, I'd be glad to talk with you more about that. Yes?
University policy allows for the chair to make the decision if the chair wants to make the decision. But each department has the opportunity to establish their own scientific review committee. Met with a great deal of resistance, quite frankly, in many of the departments, but it is a growing process here. And in those places where the chair makes the decision to make the review, they can do so. But the university policy supports having each department develop their own scientific review committee, and we use NIH's guidance as far as scientific review is concerned. But one of the problems we have is just the resistance to conducting that scientific review. It's sometimes viewed as it's another step that we have to do in research. And it really could be a very productive step for the researcher because their peers could review, we hope objectively, the research and offer improvements before it comes to the IRB. Quite frankly, the better the protocol, the easier the review. The more complete the protocol, the easier the review. The more sense it makes, the easier the review. So there is a very valid purpose behind the scientific review. And as we continue to learn in this university, some departments are getting much better. Others still haven't jumped on the bandwagon.
I agree. I mean, I think everything you've said is correct. I guess one question would be, is there any validity, and I think I can answer this question, but is there any reason for the institution to have a non-departmental scientific review process? Now, I understand there are problems with that because the first complaint will be, well, the people who know most about the research won't be sitting on these committees. It's the same argument that I think you get about IRBs, when the IRBs don't have a number of scientists on them who understand the science, just like I think the gentleman over there was saying that you need neurologists to make a determination about neurological research. In fact, certainly you do for the scientific review. It's questionable whether you need a lot of neurologists to deal with the human subject protections issues. You may need some, but not 8 neurologist scientists on the IRB and a few lay people. Those 8 scientist neurologists would probably be more appropriate on the scientific review committee. I agree with you absolutely that the better designed the protocol and the more forthcoming and knowledgeable the investigator conducting that research is on human subjects protections, the easier the IRB's job. Just like in an ethics committee meeting, when an ethics consultation comes to an ethics committee, when the attending physician or the responsible clinician is knowledgeable and involved in the ethical dimensions of that consultation, the easier it is for the ethics committee to decide what to do, because who is more familiar with the details of the case than the PI, at least, or excuse me, the physician, at least the medical aspects. And the same thing for the PI. The PI ought to be quite knowledgeable and helpful to the IRB, but that's a separate issue than scientific review. I mean, is there any benefit to an institutional rather than a department or institute, in our case, institute approach to scientific review, or do you think it best is held within the department?
My personal opinion is it would be very helpful to have an institutional scientific review committee, not necessarily composed of the same members all the time. But the problem with that is logistics. You're placing another full committee in place there. And if done appropriately within the department, if done objectively, there's absolutely nothing wrong in having those colleagues do the work.
I saw Professor Miles equivocating there when she was going like this. And so I'd like to just hear what you had to say about the idea of the scientific review.
I volunteered to be on the IRB too.
Well, it's very clear that investigators are much better if they've been on an IRB. They learn real fast.
Look, I'm a very senior person. I've done a lot of time on IRBs, and I don't think you're going to have the same problem with scientific expertise. If you got some benchtop guy reviewing behavioral work, you're not going to get a good review. They're going to say the science is no good, we don't believe in this stuff. Then it really becomes an interdisciplinary sniping issue. And I think the departments can solve it, at least in our department. We get our younger members, that's how we teach them how to do research. We get them reviewing each other's, it's the attitude of the people who are running the show. If you run it with the idea that you're going to be a space-conquering, resource usurping person, you're going to have problems all along. But I think at departmental level is good enough. Institutional, no.
And I agree with her if we can do that. And we, being a university with multiple disciplines on the campus, we would have to have more than one. We'd have to have that scholarly merit review too, because there's many differences in the type of research done. And frankly, the behavioral social would be more difficult than the biomedical to review because there's so many differences. And I agree with Dr. Miles that it's better done in the department, I think, if we can get the departments to put forth the true effort and the understanding of the purpose of scientific review. And so it makes it very difficult in the IRB when they don't understand the science or have a partial understanding, or they see a protocol that's incomplete or poorly written. It just wastes a lot of time, and it frustrates the investigator, and the tendency is to blame the IRB for the problems of the protocol.
Yeah, I think that's right. The second point about blaming the IRB is true. Is there a benefit, and we have some experience with the NIH. We're taking 4 IRBs and merging them into one. And one of the things we're doing is we are standardizing procedures for what is an adequate pre-IRB scientific review. Now, there's nothing magical about this, but having a written overview of what is required for all department scientific review might be the best you can do. That is, you leave the review to them, and maybe this exists, I don't know, maybe is there some guidance that well, then what you do is that you require someone to certify that that procedure in writing has been implemented. Well, then, the IRB should send stuff back when it's not up to snuff.
There are many problems.
I know, that's a month, yeah.
And it's a learning curve.
Yeah.
As I said, it's getting better, but there's still a ways to go.
Yeah. Well, that's all I can say is that that is a problem everywhere. In terms of the issue of blaming the IRB, I think that's one of many reasons why IRBs are under criticism. In addition to the fact that IRB deliberations may not always be methodical and systematic, is that it is a convenient lightning rod. That is, that it is such a high priority and high visibility committee, and everyone who wants to do research has to interact with it. It is a really easy scapegoat of what is wrong with research. Appropriately and not appropriately. Yes, ma'am.
Do you go through the same process with expedited reviews? We've had some nursing type research and things come through the IRB, and basically to get an expedited stamp. Do you go through that whole same process with that?
Well, no. As you know, expedited review is research that is considered minimal risk and is also on a list of activities that can be reviewed and approved by the chair or his or her designee, and we pretty much leave that up to the judgment of the IRB chair. But I think there's no reason why that ought not be done. It just depends on, not where you pick your battles, but where you put your energies first. But I think it's a great idea, whether you had a certification process or however you do it. It certainly would be easy to do. No, I don't know if that would help But expedited review research, I think because of the low risk relative to other risks, is left up to the discretion of chairs usually. Yes?
It is here, and we have a process that's going to be coming in place where at this moment, the chairs do the review, make the decisions, whether it's
And then brings it to the meeting, the next...
to come to the meeting,
You're supposed to announce, you're supposed to inform the committee, yeah.
It's merely the committee's informed that the
Right.
expedited review has been conducted. But one new process is going to happen. We're beginning to work on an electronic submission process. And within that process, the investigator will have the ability to justify why they think their research is expedited. And so that will make them think a little bit, helps help in their design, but they'll have to answer a series of questions and look at the regulations as they do that. But if it's truly expeditable protocol, they'll be able to get that done rather quickly. So, but on our behavioral side, 85 and 95% of our research is either expeditable or exempt. It's about...
Oh, really? See, that's quite unusual in our institution. That's quite... We expedite some research, but by no means the major. Yeah. Well, let me just... I know people have to leave, but let me just ask if anyone has any thoughts on whether it's even a reasonable activity to try to evaluate the activities of an IRB. Is that even worth doing? Is it worth the effort? Would it be valuable? Because it seems to me that if there was some process, for example, that, and the same thing for ethics committees, that any accrediting group, such as AHRP or, well, NCQA, the National Commission for Quality Assurance, was doing accreditations and now they're not doing them anymore, that we stand to learn an awful lot about IRBs by engaging them in their convened meetings. It seems to me we've kind of come to a place where we either learn more about the realities or we don't. And I guess I'm at the point where I'm willing to say learning more about the operational activities of IRBs is a valuable activity. And maybe I'm wrong, but...
I think it's across the board in education.
Well, that's the other thing.
You're cutting through the platitudes. SACS comes in here.
Right.
The ABA comes into the law school, and you have to have some accountability for what you're claiming to do. There has to be some measurement of.
Well, there is now paper trail.
Well, the paper.
And interviews with IRB meetings. Yeah.
Evaluation of is it doing the spirit, the quality? Are you really doing what you're set up to do?
And I think the other thing about that is that by clarifying what we expect and looking at how we do it, it'll be easier for us to say what IRBs are not supposed to do. It's easier to say when you have a clear concept of what you are supposed to do, it's easy to say, you know, that is really important that someone determine whether the PI has a conflict of interest, but that's not an IRB job. I mean, it's like being an ethics consultant. The important aspect of being an ethics consultant is to know what your job is and what your job isn't. As an ethics consultant, your job isn't to make the decision. It's to clarify for the decision maker what his choices are. The same with the IRB. The IRB keeps getting overwhelmed with activities because it is successful to a large degree, and it's very hard for the IRB to say, no, that's not our job, because it's given more and more jobs. So I think that's also an important component of educating the community and ourselves. Yes?
Well, you talked about qualitative analysis, but then you also talked about having an instrument for analysis, and I tend to attach quantitative analysis to instruments, and I'm not certain that quantitative analysis of the sort of how often do they follow the 7 steps in the letter of the law. I mean, if we really want to know whether or not they're following the spirit of what's going on, I don't know how successful we're going to be in that, particularly across the broad possibilities of what IRBs can include. And the IRBs in the NIH and here are large IRBs that take care of a lot of primarily, I'm going to say broadly understand, medical, as opposed to, say, psychological or sociological experiments. And tiny little IRB that I came from at a very small school in southwestern Louisiana didn't have any of those. Dealt with psychological, sociological, and so on. I don't know that any quantitative analysis that tries to go across these two IRBs is going to get anything of qualitative comparative merit. And so I worry that, and your comparisons of Sachs, for example, is the perfect example. I'm not positive that Sachs actually provides us with good grounds for improvement, except perhaps the opportunity to do it. But whether or not they're the sort of mechanisms that they provide for measurement are actually giving us any assistance, that's at least an open question.
I understand, yeah. Well, there's a fine line between qualitative and quantitative, right? A part of our instrument is for the context for a protocol. Let's say it's a protocol being done in the emergency room on people with acute stroke. A part of the evaluation activity of that IRB, whether they did a good job, is the discussion of vulnerable subjects in the context of that situation, in that ER, in that protocol, and how well was that done? Adequately? Thoroughly? I mean, I do think it would be possible for you to sit in a discussion in an area where you're an expert and decide whether or not, for example, you think a discussion of a clinical ethics committee was thorough or adequate to the facts of the case. So you're right, it's not quantitative in the sense of, you know, a nanomole or aliquot, but it does have to do with a Likert scale and acknowledgement as to whether the issue was appropriately dealt with within the context of that protocol. Now, there's a lot of subjective aspect of that, right? But then how are you going to evaluate an activity of human judgment otherwise, right?
But that's the point, isn't it? I mean,
That's the point.
Even reducing something to a Likert scale, I think, is taking qualitative assessment, reducing it to some sort of quantitative measure that doesn't give us what we really want in a qualitative assessment.
It appears we have a lot of people who need to hear, so why don't we wrap up there, and thank you very much.
Thank you.
Just a reminder, Professor Jessica Burton is coming from Case Western Reserve next